Hi, my name is Tiffany Hoang, and I'm a first-year fellow at the University of California, Irvine. And today at the RWCS, I'm presenting my poster, Kids Are Not Little Adults, Considerations for Pediatric Rheumatology Patients Transitioning to Adult Care. So my clinical question was, are there any nuances that adult providers should know about patients who are transitioning from pediatric to adult rheumatology care? And so I did a literature search on PubMed along with common references like UpToDate and also Rheumatology Secrets. And first, I looked at JIA and their subsets of JIA, and I found that there are in the pediatric population, they tend to have more, for example, TMJ involvement. And I think that our adult rheumatologists should keep that in mind as they're taking care of patients with the diagnosis of JIA, despite having multiple subsets underneath that diagnosis. I also looked at the Uveitis Screening for JIA and compiled different recommendations from different bodies such as the ACR, the British Society, and also the Pediatric Rheumatology Association of Japan as well. For pediatric versus adult onset lupus, I found that adult providers should consider the risk of AVN in their patients and also of premature atherosclerosis and also coronary artery disease in their patients. In pediatric and versus adult onset dermatomyositis, I think some of the highlights are that in the pediatric onset population, there's not as much ILD, but rather more abnormal PFTs and also calcinosis that may occur even 20 years after their diagnosis. So something that an adult rheumatologist should keep in mind. And finally, I wanted to touch base on the transition of pediatric patients to adult care. And I think there are three different categories that the adult provider should really think about, how the pediatric patient really needs to kind of accomplish both medical, non-medical, and psychosocial benchmarks as they're transitioning to adult care. Thank you so much for listening to my talk today.